taking the glasses off here. Okay, we have a very small group. It's good to see people. Over the last 2 days, I have met a lot of people from all across Canada and British Columbia. So we're talking about the avoid strategies. How can it be implemented into communities such as Prince George? One of the things that we discussed was that it has to be accessible. So location is important. You have to have somebody that's going to spread this message, whether it's a volunteer or a paid position or a funded position. I don't know the politics behind it. We have a large community of people between the ages of 25 and, let's say, 65 that are working. They're working well. They have kids. They have aging parents. They're looking after them both. The aging parents that decided to stay in Prince George need to have the access to all the services that everybody else does in the province and across the country. We should all have access. We're connected to a very large rural community. Our community spreads north to Fort Nelson and Burns Lake, Prince Rupert Terrace, very isolated. So you have to have people that are able to get up and go and spread that message, right? You have to be able to reach the communities that are in need of the services, right? When you move into the enablers and resources conversation, we want to have people that we can talk to. I know that there's telephone communication. You can talk to a nurse on the telephone and they'll be able to help you. I'm sure you can talk to a doctor. I think I have a TELUS app that I can talk to a doctor on a video, and the doctor's office is just over here in Victoria. So it's accessible, but when you're 65, okay, 75, you're not going on the video chat line. So everything needs to be accessible for everybody, right? Barriers, of course, barriers, for me, it's very difficult. Of course, Prince George is like we discussed yesterday, we were talking about the incomes, very high wage earners. Okay? People have earned a lot of money, they've made a lot of money, but they don't want to spend it, right? They don't want to spend it, they want to save it. They want to be able to live till they're 85 or 90 in their homes. So you have to consider you have this income, and having to spend that income to access services in the lower mainland, access services. In some cases, we've had people who have gone to Washington State, gone east for surgery, go to Alberta for operations. We need that right here in Prince George. It's a center hub. It's a catchment basin. People come here. They need the services here. We need orthopedic surgeons. We need pediatricians. We need geriatrics. We need those here. So part of Northern Health's strategy has been to recruit people, and I would really love to hear somebody from Northern Health that knows this. How are they going about recruiting the specialists? And is it happening? Are we going to have doctors that are coming from England, Eastern United States? Are they prepared for our winter? I only had to use my snowblower once, and that was last year. So it all has to make sense to you as an individual. If you're living here in the northern part of the province, you need to have reliable services, right? Transportation is always going to be a problem. It has never changed. There's always snow, there's always ice. Planes fly everywhere. It's accessible. We have BC ambulance, air ambulance service. It is used. I'm sure that plane flies every day, and every day somebody is going south Why not have the services here so they don't have to fly? You know, why pay $270,000 to fly somebody to Vancouver when they could have the services right here? I'm going to stop, and I'm going to pass it on to the next person. You're welcome.
So thanks to our table for the discussion. So we talked about some of the enablers. One of the enablers may be primary care teams, which are fully resourced, and with nurses. Well, they're supposed to be fully resourced, although some of them have a challenge getting all the resources that they need and the professionals that they need. But that would be that could be certainly an enabler. And also we discussed about getting the involvement of the community, the communities to participate in this. Potential source in the community is the YMCA. They're a big presence in Prince George. The Choose to Move program, which utilizes coach, is also potentially a resource and somebody to partner, since that's already existing, and that could be also utilized further. And we're also interested in utilizing coaches and volunteers for this, so maybe a natural fit. We also talked about developing some other partners in the community, and one of the other partners that we discussed was including industry, which has had programs like this to deliver. These are younger people, but certainly void could be utilized in younger people, and so industries, partners such as mining companies, Alcan, or people that have had these programs in the past. The other potential partner that we talked about was municipalities that have had similar programs in the past. There you have to approach it politically, from a political correctness, just to show that you're not shifting costs, that you're partnering with them, but they're not going to increase costs. But municipalities could be an important partner, and they may also be a partner in looking at food security and what food is available in communities. The other barrier that we've also addressed in our group too was transportation, and that always comes up in isolated communities, and that would need to be addressed, especially transportation to services, and if there's a better way to deliver those services without having to travel, that would be better. That was it in a nutshell. Just in the interest of time, there's a lot more things there that I took notes, but that was the major aspects of it. So I think we're at lunch. So thank you all for participating in this, and if you have any other thoughts or anything else, please let myself or Carol know, and look forward to working with you sometime in the future as we roll it out. Thank you.
2 to 3 minutes. Give us a sense of the reflections from the North particularly. And most ably, to help us with that, Ray Markham is going to moderate the session. The one thing I want to ask of you, if you wouldn't mind, is we would really like to get your evaluations. That's the way we can do this better the next time. So we really value your feedback and your input. If you can fill in those surveys, I really appreciate that. One last time, I want to shout out for our sponsors and thank them. And I want to thank you for staying here this late and hope everybody gets home well this afternoon. So, Ray, take it away, please.
Great, thanks, Tom. And the last panelist arrives. Thanks, Dave. So, I just want to share with you why Tom chose me to moderate this panel. He's quite anxious to catch his plane, and he knows that I have a motivation that's even more powerful than catching planes. It's my daughter's 16th birthday today, so I've got a 300-kilometer drive to get home, and I'm hoping to get there before dinner, so that's my promise to her, is to take her off for dinner. So if I'm kind of tight with timelines, and if I run out of the door at the end of this meeting, that's what that motivation is about. So we have a great panel here today. I talked yesterday a little bit about the intent of the whole theme of the day is that the synergy between kind of knowledge, content, experts, and application, kind of practical people on the ground, kind of in the north, in rural BC. And so how do you figure out the bidirectionality of those learnings? So we started off the session, the 2 days with a lot of research, evidence, all of that kind of stuff. And we're trying to now ground it and end it kind of with some reflections from people who kind of live and work up here. And so that's the format that we've chosen to do. Each of the panelists will introduce themselves and then give you a short reflection on kind of what's resonated with them, what they've learned, what they think might apply, those kind of things. I'd ask you to kind of then use this opportunity as a chance for you to reflect on those things in your various capacities and roles. So we'll probably take maybe half an hour for the group to go through their reflections, and then we'll open it up either for questions to the group or anybody else in the group to kind of share their reflections. So we'll start off on the far end over there and work our way this way.
You can take it and talk.
No. I'm Carolyn Bulmer. I'm from Vanderhoof. I am I guess a community support worker. I'm a member of Patient Voices Network, and I've had the honor of being asked to be here. I am dedicated to bringing community wellness to my community. In the last 5 years, we've seen some really tantamount, huge changes to better our community as far as health is concerned and caring for people. And I am a previous chronic pain patient, so I am dedicated to make that journey shorter for other people than mine was, and dedicated to making my community more inclusive in terms of mobility challenged, senior patients, young people, and I work in a number of areas with all of those. And I run a support group for chronic pain and chronic illness self-management, and we facilitate a course through UVic on self-management in our area, which has just been groundbreaking and helping people. So I don't have a lot of initials behind my name or degrees, but I'm very eager. And I just want to be the person that makes someone else's journey a little easier as an advocate as well. So that's why I'm here.
Yeah, you're up, Fraser.
Oh my gosh, now I gotta speak. Yeah, I'm Fraser Bell. I'm Vice President of Planning, Quality, and Information Management with Northern Health. And I guess the first thing I want to note is a thanks to Kathy Ulrich, our CEO, because we were sort of debating who could sit on the panel, and she thought maybe I could do it. And so, in fact, I think when we get to questions and answers, I think she's really given me the keys to the Northern Health car. So, let's figure out what we can do. So it'd be kind of fun. The objective of the session over the last couple days has been incredibly broad, and I look at the title, Caring for Older Adults, Health, Wellness, and Person-Centered Care. So that's just an absolutely enormous spectrum, and it also reflects a system that is equally enormous. And so I think, reflecting on the session over the last couple days, I actually think it has been absolutely phenomenal. And I hope you felt some value out of it as well. But the idea of bringing all the kinds of partners that are here today, there's patients, families, researchers, health providers, just across the board. And not only Northern British Columbia, but the chance to share the wisdom and learnings from people across the country has just been phenomenal. And so really just the concept of networking, I think today and yesterday has been proven absolutely. So we didn't just listen to some great evidence from some great researchers, and that would have been a really good 2 days. But in fact, we managed to do that, and we managed to then caucus and come together again in those groups to really think, well, what can we do about it? And when I think about, and I hope the breakouts were as productive for others as the one that I was in around risk. But when I think about the flip chart paper that we generated out of that, I can see many, many things that we can do. And we in fact came down to 2 very concrete things that I think we can do, which are super exciting. So, I mean, I think one big thing that has been proven to me in the last 2 days is the concept of this kind of evidence-based discourse and networking is just phenomenal. Northern Health has done a lot of work envisioning and restructuring our system to respond to needs into the future. I kind of say that's a work in progress. I think we've achieved a lot of successes. I think we have a lot of successes to come. But I think what we talked about in the last couple days, I mean, that's the fuel for the engine. We discussed some content that I can see an absolute connection and application with the realignments that we've been doing. So we've been talking about physicians and an interprofessional team in that primary care home, and a new conversation among the primary care home and the specialists and the specialized services that we have in place. This is the content of those kinds of discussions. I think we are ready to go and do some incredible work in the service of older people in northern British Columbia. So I'm super excited about that. I think Isabel shared with us the call that we have in front of us. There's certainly a challenge, but I was really heartened that those are conversations that we've been having and we are having and we feel optimistic about. There's no doubt, I think probably the workforce challenge that we have ahead of us is one that we really need to dig into and understand. But I think, again, what we heard today and yesterday is that it doesn't have to be the same people doing the same things as have been in the past. And in fact, we may actually have the sort of the motivation and the permission in northern British Columbia to do some things differently. So I'll leave it at that, and happy to have further discussion.
Okay, I'm Ian Scocking. I'm a family doctor who's done geriatric assessments for about 25 years. I'm usually the one who gets thrown in when families are flapping and risk is an issue or a question. And there were 4 of us upstairs who have been doing the physician part of risk assessments for many years. And we all find it quite easy. Everybody finds it opaque and difficult, but it's easy if you understand risk is about boiling it down to who's worried about what risk and can you fix it? And what could you do to fix it? And you only then have to add to it that whose value. Most risk arguments boil down to whose value. And I see sort of, we have a generational change, right? We have the millennials who are much less risk tolerant as both professionals and as family members. And we have the boomers who are all about independence and wanting to be doing their own thing. And so the independence risk versus safety is often what causes some of these battles or some of these differences of opinion. So I think one of the things that helps is to be risk specific. Which risk with which consequence? Second point is often when it really boils down to battling or balancing values, you can ask the patient. Even if the patient is demented, they can often tell you by pulling out their NG tube 5 times that they really don't want to be fed by a tube. Let's make sure we don't forget to go to the family. Third important point is that the job of a temporary substitute decision maker of the family is to help us make the decision that the client would make, not the decision the family wants. And 80% of the time, if you ask, what would your mother want? You get a very different answer than you ask, what do you want me to do? So we need to learn how to ask that question better so that we actually get the answer that they're supposed to be giving us. Or sometimes you have to go back and say, well, 3 years ago, what would your mom have said, and so on. And my last point to make is I think when risk is a challenge, we're only asked to wade in when there are 2 bad choices to make. If there was an obvious good choice to make, you wouldn't need me to do an assessment. And so I think one of the missing pieces in this system is somebody who has a little more experience to phone when you are wondering what's the right thing to do about risk. I think the caregivers and the families and the people who are struggling with what should I do with mother, lots of times there's different risks, right? The daughter is simply wanting not to be woken at 3 o'clock in the morning by mom being confused, but mom wants to be independent and stay in her house as long as possible. And so you actually need to know how to balance those. So I think sometimes some of these decisions could be made by a team, and we need to create a team and a network, and there are proposals to do that. But those are the few things I was going to say.
Hello, my name is Julie Dollywall, and I am the Director of Community Services here in Prince George, working for Northern Health. And what that means, what does community services mean? It means a lot of things. There's a variety of programs and services within that portfolio, so things like home support, home care nursing, the interprofessional teams, public health clinics, urgent and primary care center, and a few other things. So it's our suite of services in the community. And I've been in that position for about a year. And when I think about the last 2 days, there's many things that struck me, some professionally, and I think like many people in the room, personally as well, as I am also an engaged daughter of 2 parents that are 74, that are aging with attitude, and I love that about them because they're very inspirational, and have recently also just experienced some changes in their health. And because they live away from Prince George, they live in 100 Mile, supporting them as I guess the appointed child who works in healthcare, which is, I'm pleased to be a part of that, is going to require something different. And so it's learning, I think, and navigating that and listening to the many stories of wisdom in the room. I think a few things struck me specifically, and one is around just community and activation within the community. And I think about an opportunity my husband and I had a few years ago, living in a rural, on an acreage west of town, and having a neighbor whose husband had early onset dementia, and that we were able to participate in a community plan because he was young at the onset of his dementia and quite swift and could run away, and which means there was lots of opportunity for him to get lost in the woods. And there were times that we found him in our yard, and we had a plan together with the family on who to call and how to approach him and how to make sure we were able to collectively keep him safe. And I'm sharing that because we were really keen and eager to be part of that plan. And that's something we want to continue. And as we were talking the last few days, it made me think about, how do you get that out there? And I had a conversation with Olive last night. We were talking about, how do you let people know you want to be involved? How do I let people know that I could be part of their life even in this way? And so it just got me thinking about how do we start looking at ways to alert how you want to be part of that in your own community. The other piece that struck me, and I really enjoyed Joyce yesterday in her functional fitness and getting everybody up and activated. And I loved seeing people perhaps step out of their comfort zone and participate. And it made me also think about my mom, who's had recent knee surgery, and her mobilization has changed, and I'm seeing her physical abilities decline. And I've fallen quickly into the role of lecturing her around what I think she needs to do, and it's not working. And it probably didn't work with me either. And it got me thinking, because when you have space to think, you actually can come up with some good ideas. And what I wanted to share was just what I want to do next, and that is, instead of lecturing her, I'm going to invite her to Skype with me a few times a week so I can do it with her. Because what's 10 minutes a day? I talk to her all the time, and why not try something different that I think will encourage her? It will give us a time to spend together, because we don't live in the same town. And I know it's going to make me feel good knowing I'm helping her, because their goal, my mom and my dad, is to live at home in their own home, and that will be more important to them than anything. So yeah, and then lastly, I think the last point I want to share is around the term frailty, and it really has stuck with me how easily that word has come out of my mouth or slipped off my tongue, not really fully realizing the stigma that can come along with that. And I really appreciated that that perspective, because it will certainly change how I approach that term. So thank you.
Thanks. My name is Rita Weeb. I come to this conference as a patient partner, and I like to think of it as an end user. So I'm involved as a patient partner on a number of levels. It was the BC Support Unit that I am a member of, the BC Support Patient Council for the province, is how I come to know about this opportunity to put this symposium together. So I am on the planning council of that. I am a member of Patient Voices Network. I am a family engagement person for the BC Cancer Agency, and I've been doing a couple of national engagements as well. So I have opportunity to see how, not only we here in rural BC, how we work, but how on the province works. And one thing that I do know, we have probably one of the best systems of patient engagement anywhere in Canada. That's just my opinion and what I've seen. And I was born and raised in Quesnel. I come to the big city in my 20s, which was called Prince George. I moved down to the Okanagan in 1995, thinking that must be the greatest place to go. I discovered that the Northern Spirit doesn't live there, and I moved back here in 2000. So I am a true Northerner now. I mean, there's no place like it. I came to be a part of the whole patient engagement thing, which I have found is really a growing industry. And it was for a couple reasons. One was because, some of you had a chance to see my presentation yesterday. Some of you might know me through Aging with Attitude, through the TV and radio programs I do, or other speaker engagement platforms as well. But I came to the patient part of things because of, one, my passion for the 45 to 64-year-old demographic, and the other was because my 38-year-old son had developed pancreatic cancer a few years back and chose to go out via MAID. And I, as his mother, had to walk him with that journey, which was very tough. There was nobody to talk to out there. And, it was a different health authority, and so there was a lot of miles there. It was in the interior, it was in Kelowna. And so that was a tough thing and there was no one to talk to, and that's one of the other reasons I became involved as a patient partner, because I feel, there's a need for advocacy out there. And when we've got new things like the MAID program, Medical Assistance in Dying, when that's new and there's nothing that people can talk to, nobody to talk to, I'm very willing to share my personal stories. And that's largely what I do with not only on the national engagement level, but on the through the BC Cancer Agency as well. So, I'm very open to sharing my personal story, what it was like. MAID isn't just something for the older person. My son was 38 years old. And, it can happen to any of us at any time. We may have to walk that walk. With the kind of work I do, community outreach, marketing, that kind of thing, I really so believe in synergy, collaboration, working with others. It's something that we learn to do naturally here in the North, and symposiums like this have brought so many people together, and so, we're all in this room together. We don't have to operate in those silos. We talk to each other, we help each other out. And, it seems like everybody's been so open, like even the Canadian Frailty Network, they're from way across Canada. And they've brought this opportunity for us Northerners to be in the same room together, to talk together. And that's collaboration. There's the academic health sciences, which is the BC Support Unit is a part of. That's, and just thanks to them and Tom for putting this together and bringing this to Prince George. From my understanding, we are the first in Western Canada to roll out the Avoid program. We have a very special gift up here. We know how to communicate with each other, talk to each other, and talk across the miles. We've become used to being able to get on video conference because that's what we have to do. It's always nice to get together. One of those nice perks as a patient partner, get to be involved in being invited to some nice things like this, and sometimes there's even a little plane ride involved. It's kind of nice. We don't get paid to do what we do, but it's nice to feel that our opinion matters as an end user. And I've got nothing but, sometimes I feel a little bit like a celebrity that, I get so much, there's so many people that are appreciative. And I used to think that people in health unit authorities and that sort of thing were the people that knew it all. And I needed to be empowered to speak my mind too, and they allowed me to do that. So I just want to thank everybody who was involved in letting people like me speak to them about the things that are bothering me. And some of those things in life that we have to deal with are very tough things. And, to let us talk through our tears if that's what we had to do. And there was people there to hear us. And so, my message is that we're all in this thing together in things that we go through. There's different groups out there. There's UNBC, they've got the Northern Centre, there's Patient Voices Network, all about synergy, all about collaboration. And there's, of course, provincial bodies and national bodies as well. So, we're not so remote as we might think we are, and we're actually positioned as a first in Western Canada to be an example to what is possible. So I just want to thank everyone again for hearing me and letting me be a part of this. So, and yes, we're all in this together, aging with attitude.
Thanks very much. I'm Dave Snadden. I'm the Rural Doctors UBC Chair in Rural Health, and you might be wondering, like me, what that is. And I'm an academic, so I am based here in Prince George. I've been here since 2003, and now I get to work with Ray Markham in the Rural Coordination Centre BC, and I'm part of the Department of Family Practice at UBC. My role is to keep reminding the people in the big city that the rest of us exist. And I have in my role been able to travel around many, many rural communities and speak to the providers and the mayors and the patients in those communities, not just in the north, but right across the province. So I was asked all of us were asked to, what's been your reflections on this meeting? Isn't it great to get together in such a diverse group? I feel I learn so much when I hear voices from everywhere that is involved in this. So I think getting together, we can do things together. Prince George has a history of making things happen, and it does it when everybody's together. So this is a really good forum for that. I have to disclose, I'm a senior, and Isabel McKenzie this morning was talking about stereotyping, and I'm thinking, that's me she's talking about, And I think, and I'm thinking, this is our future. So for all of us, what we're talking about is going to be our future somehow or other. Yeah. Therefore, I'm thinking we better get this right. And there's a few things that make, that I've thought about around what we should be beginning to think about. I was quite intrigued at the evidence brought to bear, particularly yesterday, and some of the great work that people are doing. What really strikes me is, how do we then take that great work and modify it and apply it in our context? So every rural community I go into is different, and how you apply things developed in urban centers in rural areas is different. If we don't modify it and adapt it, and if we don't give ourselves permission to do that, we're setting ourselves up to fail, because the metrics people will create will measure us against urban metrics, and I don't think that's fair. We have huge inequities that we need to deal with. So that's one thing I'm taking away. I think the other thing which, it comes back to the stereotyping piece, is don't do it to us, but do it with us. And more and more, when we look at how healthcare is delivered, it's on guidelines and protocols. We have to find a way of having better conversations with elderly people, and I'm one of them now, and the people caring for them about what their wishes are, so that we can adapt and we really can work with people about what's feasible and what's best for them. And in other words, we mustn't be patronized and we mustn't be patronizing. And then that leaves me kind of with my final thought, is that if we're not doing it to me and doing it with me, how do we have those conversations embedded into our educational system so that people are much better able to understand from even when they enter university or the healthcare schools that this is an exercise in relationships. It's not an exercise in the application of problem solving. And final thing, eat well, speak to people, and keep moving.
Great, thanks. Any comments, thoughts, questions, reflections from the floor? Dick? There's a mic coming.
I'm here. Name and
Yeah, I'm Dick Raymond. I'm the elder lead. I just want to comment on Dr. Snadden's comment about talk to me and with me, and I think that reflects that quote, which I hope you could read again, about the elder, who want, we deprive them of one of their greatest values, which was to be judged or spoken about in the same way by someone their own age, their own peer. And I think that's what
You're asking me to read your writing, Dick?
Yes, that's going to be difficult.
An old person suffers the loss of one of the greatest human rights. He is no longer judged by his equal. Yeah.
That's what Dave's talking about, I think, yes.
It was a quote that Dick had shared in one of our previous sessions. Okay, thanks, Dick. Any other thoughts, comments, questions from the group? Reflections, learnings, anything you've picked up today? Any aha moments that you've had?
Can I comment a little further now that I'm
Yeah.
not so nervous?
Sure.
I'd just like to say that I have a lot more faith that our medical system will adjust and will become more regional, which I feel is totally necessary from Prince George North. I don't think there's a one-size-fits-all philosophy. And what I heard today was the beginning of heading in that direction for medical care, listening to patient voices. It's going to mean a whole rewriting of our medical system from the ground up, whole cultural change. I feel that's a lot more possible now after sitting with some of you wonderful people and listening to the conversations. And we're going to cover the distance, which is the biggest problem up here in a rural community, is communication and distance with patients and doctors. And I have more faith after this whole conference that that will happen. It won't be overnight, but it'll be within, I'm hoping, a couple years at least, before I get too much older. And I think this whole conference was worth it. And it was an honor to meet some of the people that I did here today and network with some of you who will be getting an email from me and sharing information. So thank you for letting me sit up here and say that to begin with.
Great. Thanks, Caroline. And I think just to pick up on what you're saying there around there, I think we have an opportunity at the moment around a system change, and I think it goes beyond care of older adults. I think care of older adults is a potential catalyst for that process, and really kind of in the last session this morning, some of the comments that Rita had made really kind of resonated with me, and there were a few threads that came together kind of around that piece where Rita was sharing her journey with her son and her not knowing who to connect with in the system. And there were people there, but it was just how do you find them? And then us talking through, as a group, talking through, well, that's just one piece of it, and there are so many other pieces. And so, and then there was a comment made around, Northern Health, they're trying to move to this approach of every person, the first person you connect with is the right person. So that's not my job, go speak to this person, but it's let's help figure it out together. And one of the things that we kind of have really been kind of at a provincial level been working on is this idea of we have a system that really drives caring for people as healthcare providers, and it doesn't make it so easy to care about people. And so really one of the big opportunities that I think we have in in this work that actually has ripple effects across the whole of how healthcare is delivered is actually having a healthcare system that allows the people in the healthcare system, working in the healthcare system, to care about the people they're working with. And that's their colleagues, their peers, but also the patients and also the people up at the top, kind of the people who never kind of access the system. But, and I don't think that's something you have to make people do. That's something people naturally do. It's something actually that we just need to get rid of those system barriers that don't allow us to do that. So that was kind of one of the big aha moments, and it was crystallized actually through a number of the conversations that happened over the last couple of days for me.
I think that's one of the powers that I saw of this networking approach is that, you know, I'm from Northern Health, and I'm the first to recognize that we create structures in Northern Health, and those structures get sticky and they cause trouble. And we all want to change them, and I think, how do you change? What are the precursors to actually being able to make the change? And it seems to me that conversation like this allows the conversation to get to the people who need to make the change and create that motivation. And that makes it a whole lot easier for those of us who need to do things with the system to change. So I think it's incredibly positive, the conversation we've been able to engage in, because A, it's produced some content that I can understand what we could move forward with, but I think even more powerfully, it's created a little bit of an incentive, a motivation. I mean, we're getting a bit of a call to action, I think.
Some of us are going to hold you to that, you know.
I just want to stress the importance to advocate for changes in the education system. And I work in health education myself. And I know with my nursing students that when I stress the importance of keeping the patients first, looking at the abilities and not what they're missing, and especially work with examples, storytelling, that makes an impact. I just actually interviewed a former student of mine for a job, and so she told me, like, 5-6 years later, she still remembers the stories. And when she works on the floor, how often she thinks about what we taught her in the courses in class, and how it comes back and is like, hey, stop and think and apply the really patient-centered care.
Absolutely.
Show it, work it, walk it.
Great. Yeah. Cool.
Yeah, thanks very much. So I'm Sterling Bryan. I'm the Scientific Director at the BC Academic Health Science Network, and I just want to say what a privilege it's been to be here for the last 2 or 3 days in Prince George and to learn from the experience that is here in the north. I wanted to sort of link the comments made by Isabel Mackenzie and this sort of risk conversation. So my wife's name is Anne. And I think she's more of a Jane than an Anne, at least I hope she is. But I found that a really helpful sort of characterization of variation and the importance of recognizing variation among seniors and actually respecting that variation. And I think the linking of that then to the conversation around risk and acknowledging that some people are very comfortable accepting risk, others probably much less so. And we should actually see that as an opportunity to empower people. And that empowerment can be around, allowing folks to acknowledge and to accept higher levels of risk. And I think that's an inevitable part of delivering high quality healthcare and should be part of delivering high quality healthcare. And Jim Mann was sharing with us this scenario in long-term care facilities where, he actually observes people clearing tables and doing some washing up and cleaning their room themselves. And, actually that should be something that we allow people to do in certain circumstances rather than this notion of safety all the time. So I think that conversation has importance for us, and I think that risk conversation is a really important one for us to take forward.
Yeah, great. Thanks, Trey. Any comments from the panel on that?
I'd just like to comment too, just on the rolling out of the Avoid program. I was really happy to find that there was actually scientific research behind what they were talking about, and that really wasn't our inevitable lot in life, was to get that dementia frailty thing happening. So I was very happy to help with that, and I think it requires a lot of education that people need to do, and I think there's a lot of personal accountability that has to happen as well, and empowerment of people. How we do that, I don't know, but there's a lot of work to be done around that, and personally I think that people need to be accountable for their health. And when we talk about risk, when there is a risk involved, whether it is my parents, my kids, my spouse, whatever, I mean, I like to know the options. I like to know, well, how to make a decision and not have somebody make that decision for me. I know there was a point of time too, and this was, my mom lives in Quesnel, and there was a point of time that she was showing some signs of some Alzheimer's, and I thought for sure she was coming down with Alzheimer's. And so I went looking for help too, and there's a little bit of help out there, but then I found out that sometimes these signs can be a medication change. So I went down to her family doctor in Quesnel, and he promptly kicked me out of his office and told me that he could lose his license for talking to me. So, I mean, it's those kinds of things, and I mean, my mom won't let me forget that. I mean, now that, I mean, maybe I did, raise a little flag there, and maybe he did have a look at her medication, I don't know, but I was one of those family members that nobody really told me where I could go, so I went bursting into his office, and I promptly got kicked out.
Thanks, Rita.
So talking about reflections of the conference, the first one that came to mind, I think, was the funniest and also the most insightful. And it was the risk conversation that we had earlier this morning where the two of you, Fraser and Ray, were facilitating in a giant room full of people, and we're trying to figure out, what is risk and what isn't it and whose is it and who's in the room and who's a physician and who's an administrator. And then you ask the question, who here is a community member or a citizen? And there was 2 hands up and then 3 hands up, and then we all kind of looked at each other and said, that's a trick question. So I think that's important to keep in mind, is that we're all people first. And I think that if you lose sight of that in your work, then that's a good way to sort of ground yourself and start the process of being insightful all over again. We're all people first.
Great.
On the panel yesterday, I said that a priority is knowledge transfer, knowledge translation, taking the information and spreading it around. And when I was head of what is now the Tourism Industry Association of BC, my chair was at 100 Mile House, and he used to drill into my head, and consequently I still remember it, that what works in Vancouver doesn't always translate well in 100 Mile House. So I just want to acknowledge and congratulate the organizers in what I think, I don't know how many people are here from the north versus the south, but
how many people from the north?
But there's still more than just a handful of people from the south. So I think that this gave the opportunity to learn from each other, for the people in the south to learn about some of the challenges in rural areas, and vice versa. So, thank you.
Great, thanks, Jim. How many people from the south? Yeah, so great. I mean, and I agree totally about the synergy there.
Hi, I'm Laurel Redley. I'm a patient partner. I really appreciate the opportunity to have been here. I found the conference an excellent balance of information given and input offered. The whole patient voice thing, we're still pioneering it. I'm seeing a lot of progress, and I'm really excited. I'm hearing a lot about taking responsibility for our own health and shared decision making. And to me, that sort of highlights the importance of, as a society, we really need to work on health literacy. We need to start teaching children. It's all very well to say we can take responsibility for our own health, but we're not all enabled to the same extent. And so I'm really glad to see the Avoid program working out. That's part of the educating the public and increasing health literacy. And again, with respect to that, I'm from Vancouver, and I really appreciate the opportunity to come to the north, to be able to give some input and to be able to learn a little bit more about the challenges and opportunities up here. So thank you very much.
Great, thanks.
Yeah, I think I'd also pick up on the other side of health literacy is the obligation on our part as providers and administrators to get better at having those conversations as well. I mean, I think we do kind of come to public meetings and we bring our acronyms and all our titles, but so I think there's an obligation on our part as well to get better at that.
Yeah, and I'll just comment on the kind of north and south thing. Again, I think, the intent, so part of the conversation, our risk piece was who wears various hats, but it's not to silo out or to divide. It's actually really to point out the synergy and the fact that one can't move without the other. And so they're both kind of really important perspectives, and having them both together is actually hugely important.
Hi, my name is Shelley LeBritton, and I'm here as a private practice person at the conference, and just recently switching over to seniors as a client group focus. So there was a lot of new learning for me in this room today, so I feel kind of overwhelmed with a lot of the systems that I was exposed to. But having said that, I come from social work. I'm a registered social worker, and I heard a lot of conversation about social dynamics of health and the importance, but I'm not seeing the expert, like say from our field per se here. And I'm just wondering, how the BC College of Social Work is kind of included in all of the work that's being done right now, or the BC Association of Social Work, how that translates across provinces and whatever their governing bodies are. I'm very encouraged to hear the conversation, and I do agree that, the social dynamics of health are just as important as the physical pieces. But having to work in an underfunded industry where a lot of the positions are part-time and our caseloads are huge, I just am hopeful from this particular conference that our voices are going to be more included on that, and just in a reflection that I would like to see an expert from my particular field up there, because I've heard a lot from, and even when we broke down into smaller groups, I just realized how many nurses are actually kind of like in the administration and managerial levels at the healthcare systems, but I'm not seeing the social work, so maybe that'll be me at one point someday,
yeah.
Right? But anyway, it was more of a comment, and I appreciate being part of the group today.
Thanks for that.
Hi, my name is Sean. I'm a paramedic with a provincial ambulance service. I just want to thank everyone, the organizers, for this. It was a great learning experience for me, and I'm going to definitely put it into my practice for patient care. It was a well-organized symposium, and I'm glad I went, and thank you again.
Great, thanks very much.
Ray, can I get 2 words in here?
Yeah, so I think,
Not to end. No, I got a question. I want to test this panel, actually, because, Jesse, there's probably some other questions. Don't lose them. But, one of the things in planning this, we took a section of the trajectory of life, basically, and healthy aging, and we've taken it out to frailty and dementia. That's a large trajectory. We haven't gone before that to talk about social determinants of health and how they allow us to approach aging in a healthier fashion. Maybe that's another future conference. We also haven't gone to the back end, although we've referred to it a couple of times over the last 2 days, and we really haven't talked about end-of-life care, because we all die. And we all know we're going to die. And it's perhaps not so much the death that we worry about, but the dying process. So maybe the next one, building off the end of this, perhaps should be end-of-life care. And so now to the test of the panel. Sorry. to raise this one late, but I'd really like your opinion on a current health policy issue that I think is going to be in our faces and could well overwhelm our best interests in doing the right thing. And it has to do with how should we think about medical assistance in dying with people with dementia and/or frailty. It scares the life out of me when I hear certain kinds of cases like I've recently heard, and then it makes me feel like I'm not thinking about it properly when I hear about other cases. Do you have any suggestion about how we should be thinking about that at a systems level? Because we better hurry up and get ready for this, because that one probably might be a little tsunami.
So I'm hearing two pieces to Tom's question. One is next steps for the North around this, and then if you have any thoughts or comments around the medical assistant in dying with dementia. I don't know, Ian, it looks like you were ready to comment.
So I'll throw out Dick's Newfie approach, which is to talk to the patient earlier and to get them to make an advanced care plan. Legally, they can do it ahead of time and say, under these circumstances, I would want that. But once they're demented, they can't by the law, and the family can't consent to it for them by law. So there's actually a hole in the legislation. The only way around it, is one of the things we talked about, is I think we should have an annual advanced care planning conversation with every patient who's got some health issues starting at 65 or starting when they have a number of diseases once a year. They become much more able to have that conversation. And when you have the conversation, you find out who the person is that they would most trust. Lori McCoy has a question. Who would be the person in their family that would pull the plug? Who do I need to talk to? Who will be the one you want me to actually get to pull the plug when the time is there? Because they'll often know that their partner won't do it or whatever. So that's part of her conversation. I ask about, would you donate organs, and who is the person that you would trust the most to respect your wishes? And that's what I put on my care plan. So if we do that every year with family, I think we can have some of the main conversations up front and at least know who would want that versus who would not want that.
Thanks, Ian.
Carolyn, you were going to?
Just from my own experience with my family and my parents, that's a really tough conversation to even introduce and to have. And my mom and dad's generation is, no, you're not talking about that with me. We're not discussing that. And not even with their physician. And my dad has had a couple close calls. It's in a will somewhere is how he's looking at it. But assisted end of life, I don't think so for him. But he hasn't been clarified. He doesn't clarify it. And I think it's a difficult subject for a lot of people to have with their parents. I don't know what the answer is or how to make that more comfortable in our society to actually have those conversations. I think it needs to happen.
Great, thanks, Ron.
I'd like to say a little bit about medical assistance. Having been a person that was through it firsthand, and when your kids go through it, you sort of look at every process as a parent. It was just last week I said to my mother, well, if I ever get sick enough that I'm dependent on medications to keep me alive, I might as well just go off medications, and if I'm going to die within 3 months, then I might as well apply to the MAID program and get my 2 signatures on there. So that's, it's allowed me to talk a lot more freely about it. The fact that my son was 38 years old, really, it's a very neutral effect on the people that are older, because we're not talking about, exercising MAID on them. We're talking about a very young person. And, with my experience, and I personally don't like the term advanced care planning. I think it's important. But, the situation, and I'll just say a little bit about my son. When he discovered it took about 6 months for the diagnosis to become official. So, meanwhile, I'm thinking, well, if that's cancer and it's growing in him, like it's taken an awful long time. But when the time did come, and it was about 6 months, or, shortly after he found out, within 2 months, he says, well, Mom, could you check out Dying with Dignity? He didn't know what it was called. I didn't know what it was called. So I phoned all across the province, and, and I finally found out that this thing was called MAID. And, through our discussions and being able to have discussions very candidly, and him talking about what he wanted to have done, you know, if he eventually went through with this MAID thing, you know, it allowed us, after the event had passed, it allowed us to know what he wanted. Now, Trevor, that was my son, he really liked his beer. I've told a few people this story, but he really liked his beer, but I was fortunate enough that in that last 6 months of life, he was too sick to drink it. And, you know, he made it clear that, he just liked it, and he made it clear that he wanted to be cremated. He made it clear that he wanted his ashes given to certain family members. And when it was come time for that celebration of life, you know, we had talked about all of that stuff. And being that he was a little bit of a jokester, I created 6 little boxes. I painted them kokanee colored beer blue, brought him to the beach in a beer cooler, and we had his celebration of life on April Fool's Day, because that's what he would have liked. And it allows us to have those discussions. I mean, there's been some very beautiful stories about MAID and that sort of thing, and just having gone through it and to be able to talk to real people about their experiences in going through it, you know, allows us to think about it on our own. I know that little box of Trevor's ashes sits on my mom's cupboard in Quesnel, and her religious beliefs, they don't allow her to think about it and apply it to herself. But, you know, and that's okay. You know, it's there for her to think about, talk to her friends about, if that's what she should want. But it's about planting those seeds and preparing that space for that conversation to happen. And it can be a very beautiful experience. And so after having been one that's been there firsthand, and seeing the healthcare system, even the Ministry of Health, you know, getting on board and wanting to hear my story and putting a committee together so that they can, you know, create some policies and maybe some brochures around this thing. You know, I think it's very special. I think we've come a long, long way. So I just wanted to share that little bit about firsthand experience.
Great. Thanks, Rita. And again, just to pick up on one of Rita's comments at the last meeting is this, and I think one of the things that we identified in our group around tangible next steps is the importance of the end user, as Rita calls it, so the person receiving care, but having that perspective in shaping any conversation, not just being consulted, but actually shaping right from the beginning, kind of right through the implementation or whatever, even if it's from the difficult conversations like MAID with dementia to whatever other initiatives we look at moving on this piece of work. It's hugely important. I think we're done. I'll hand back over to you. A round of applause for the panel.
Thanks, Ray. So you can see why we had such a successful conference.
Great job.
We're finished. Pay attention to the website for the proceedings. I don't think anybody needs a summary of this. Thanks again to the panel. Safely home, everyone, and please enjoy your long weekend. I worked good. Thank you.
Yeah.
So, good event.